Okay, it's 5:30, so I really appreciate everybody for showing up for the Ottumwa City Council work session tonight. I'm going to call the meeting to order, and Chris will take the roll call. Oh, yeah, let's do the Pledge of Allegiance first. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Now, Chris, you do your roll.
Councilmember Cavanagh.
Here.
Councilmember Reed.
Here.
Councilmember Galloway. Here. Councilmember Hoffman. Here. Councilmember McIntyre.
Here.
Mayor Johnson. Mayor Johnson.
Oh, I'm sorry, here. The next item is to approve our agenda for tonight's work session. Is there a motion to approve?
Motion to approve.
Second. Chris will take the roll.
Councilmember Cavanagh.
Yes.
Councilmember Reed.
Yes.
Councilmember Galloway. Yes. Councilmember Hoffman.
Yes.
Councilmember McIntyre.
Yes.
Okay, before we get started with our discussion tonight, I just want to set a little context for why this meeting's been called, because I was kind of the one that suggested that we do this. Over a year ago, City Administrator Rath and myself and some of the Board of Supervisors had some discussions with the Ottumwa Regional Health Center on the future of the ambulance service in Ottumwa and Wapello County. At a meeting in April of 2024, when we met with William Kiefer, who used to be the CEO. He's not the CEO of Ottumwa Regional anymore. I just met with the new interim CEO today, Michael Covert, and he just started. But at that meeting in April of 2024, it was pretty clearly expressed to us. And if Phil or Brian or Darren want to chime in, feel free to do so. We've been told that the hospital had lost $1.6 million over the ambulance service over those prior 2 years, and that they really were seriously in a position where they no longer wanted to provide the ambulance service. He said they wouldn't drop it until there was some kind of planned transition for it to be moved somewhere else. But he was pretty adamant that they didn't want to provide ambulance service anymore because it was costing too much money. And he also said most of the LifePoint hospitals that they own no longer provide ambulance service through their LifePoint hospitals. That's what we were told in April of 2024. He also said he would develop different scenarios for the city and the county to look at, just for discussion purposes, on what are some of the types of things that could be looked at in the future if the transition of the ambulance service did in fact occur at some point. We waited for those options, and we waited and we waited. 6 months later, we still hadn't gotten them. I emailed William Kiefer last October, asked him if he was still planning on providing the city and county with some of these options to at least look at. And he said he would get us some options. So about a week later, he finally did get us some options. The Board of Supervisors and Administrator Rath and I have copies of those options. And that's all they are, is just possible scenarios on how you could look at possibly sharing in the funding of an ambulance service in the future. I don't know if one's any better than the other, but they were 4 different options. So after we got the options, I requested that we have another meeting at some point. So we finally scheduled another meeting in February of this year with the hospital. Mr. Kiefer wasn't there. He zoomed in from Texas, which is where he lives. And so he provided kind of a little different story to us in February. He said that they had increased the salaries of their EMS and their paramedics, which they needed to do because it's my understanding that they were low compared to other area emergency management personnel. So I think that helped because they were having trouble getting enough people to work for them. So he said, we've invested in increasing salaries. We've increased some equipment that needed to be put on our ambulances. And he says, we're about breaking even now. So when he said that, I said, well, that's good to hear. Are you still wanting to look at moving the ambulance service to some other entity? I never really got a clear answer from him that day. So I don't know where the hospital is currently at. I talked with Mr. Covert this morning about that, and he doesn't know enough about it yet to really have an opinion. which is fine. So I don't know if it is near the emergency that we were told it was a year ago. I don't know if they still want to transition it or if they're willing to continue to provide the service if they can get kind of some subsidy from the city and the county. I don't know. We still don't really know where the hospital's coming from. So I believe the Wapello County Board of Supervisors had talked to Tim Richmond and have kind of delegated to Tim to try and put together this new EMS advisory council for Wapello County that's going to be multidisciplinary in nature. And I think that council is going to be tasked with looking over this whole situation, not only emergency management services in general, but also the future of the ambulance service. So there's not going to be any decisions made. This is a work session. Council, Board of Supervisors aren't here to make any decisions. We just wanted to have an initial discussion with them before this council gets established. Hopefully, this spring, early summer? Do you have any idea when that's going to be up and running, Jim?
After the third reading of the resolution, which will be in April.
Okay, so
April or
hopefully
May.
by late spring, early summer, that council is going to be able to be functioning, hopefully. And I think there'll be a lot of things for that council to address that we're not going to get into tonight. But I really wanted to call a meeting just because we had never really discussed with the city council what their thoughts are in general about emergency management services, or what ideas might they have about how they think the future of the ambulance service could be provided. Same way I thought it would be good to involve Wapello County, so I did invite Wapello County supervisors to this work session. And I'm glad Brian and Darren were able to come. Carrie couldn't be here tonight, so I'm glad that they're here too. So even though this is an open meeting and people are going to be able to speak and say what they want to say, my hope is that we're going to be able to primarily focus on having a robust discussion between the city and the county on these topics, because that's what the purpose of this meeting is for. I believe our fire chief, Sean Canto, wants to do a brief PowerPoint on emergency medical services. So before we have him do that, Phil, do you have anything you want to add or say, or Brian?
Bill can go first.
Oh, okay. No, I mean, I think you laid out kind of the history of things there, and there obviously was a lot of uncertainty as to where things were going, and previously the city council wasn't in a lot of those conversations. They'd been briefed from time to time when there was anything of note, and for a while there wasn't anything to really advise on. The city, and at the moment, the county, are not obligated to provide EMS service. That is part of what the central service movement would do. But at the moment, nobody is required to provide ambulance service. I think we would all agree that the community expects it. And so even though we're not required to, it has been provided and has been provided for the last number of years through the hospital in Ormix. That said, I picked up on the same thing that the thoughts were that the hospital may be looking to transition out. And even if locally they weren't, the parent company may opt to do something different. And so there is that concern and that fear that we could be left without ambulance service. And that was part of the reason for looking at what the city needs to do, what the county needs to do to maintain a service. And so I think there's a number of things, and we talked about that. It has to be a multifaceted, all-inclusive approach. And I think that's why we're all sitting here around the table, and the people on the outside of the room have an interest as well. And so I think that's where we're at right now.
Thank you. Brian, do you have anything you want to say on behalf of the county?
Thank you. About 2 or 3 weeks ago, I was in a conversation with William Pieper and the new CEO. At that point, the discussion was that they aren't wanting to exit the ambulance service, that they want to maintain it, but that they would want us to be participating in some way to support what they do. And I'm a real advocate of that at this point, and that's why I'm the one that's pursuing the essential service concept. And also then that puts us in a position to do a small tax levy that can create some revenue to support the ambulance. And there's a lot of ways we can support through dispatch, through training, and through some direct assistance programs to support what we're already doing, both in the rural fire departments and what you're already doing in the city fire departments. So,
I don't know if everybody's aware, but the county is authorized now under Iowa code where they can put an essential tax levy up to vote of the public. It has to require 60% approval. But if that tax levy passes, and that, like Brian says, another way that there can be additional revenue come in to help subsidize and support an ambulance service or dispatch or other related parts that go along with emergency medical services. So at some point, I'm sure Wapello County, after this council gets put together, is going to have to decide if and when they want to put that to vote of the public, whether it's this year or next year. That's something that the county will have to ultimately decide at some point, but input hopefully from the advisory council. Darren, do you have anything you want to say from the county's perspective?
No, just that Wayne Kiefer had, they were 600,000 in the hole. The last meeting, they were actually $500,000 up. They were showing profit. They had purchased all new cots, which they initially wanted us to buy, raised the fees and fixed all 4 ambulances. So they put a major investment in, so it's still turning a profit.
Well, I'm glad that Brian shared that information because that's a little bit more definitive information than what we had at that February meeting where it was kind of left up in the air of what the hospital was going to do. So if they want to hang on to it, if they can figure out a way to have the other entities help support it, that's good to know because that wasn't kind of what I was walking away from that February meeting thinking.
So you said they were 600,000 in the hole, but they're now showing a profit of what?
Happening. Sure.
It's a huge
Over
turnaround.
$1 million because they invested those costs for 220,000 police and they bought 4 of them.
See, that wasn't information that was shared at our February meeting either, so that must have been information.
No, that was shared.
Not the $500,000.
No.
I knew he said they were breaking even. I don't remember him
No,
saying.
yeah,
The number wasn't shared. The number wasn't shared.
I didn't think it was either.
Yeah. Yeah. No. He said a little profit, but he didn't give us a number.
I don't remember him saying $500,000.
Barb's not right. I think we can move on.
The, part of that, I think too, is looking at the level of services being provided to the community and making sure that it's adequate for what people are wanting to pay for. And, I think maybe part of the reason for that turning of a profit was reducing that certification level and going from paramedic to the conditional. Well, because you don't get as much in expenses.
When you're not required to have a paramedic on every route.
Now, that's my assumption. I'm not seeing the books or anything. I'm not asking you to see the books, but there is there's some things that if you don't have the same amount of expenses, then the revenue comes in and can help offset that.
Does anybody from the county or the city have any more comments, initial comments they want to make before we have Sean do this brief presentation?
one concept that I like to pursue is this idea of doing the small step soon. And if anything happens in the future where we have to take over, we have taken the small step to begin the process.
Yeah.
So it's a good first step.
Something could change pretty quick, perhaps.
Yes. Thank you.
And like Phil said, it's always one of those things where locally the hospital might feel one thing, but corporate might come up with a different idea that they want to enforce, and so it could change over time. But I agree. I think it's good to be proactive and have some planning instead of waiting till somebody says you got 2 months and we're quitting. So, anybody else around the table here have anything they want to say first before we show the PowerPoint?
I'm all for planning ahead for anything, but I was one of them that wasn't invited to the meeting, so I'm just hearing hearsay from other people, and no one has told me the same story.
When you say meeting, you mean the one that happened a couple weeks ago with the hospital and the
Yeah.
supervisors that?
So first, I think before we go too far into this with public and everything else, is if the CEO of the hospital wants to keep it, well, then all this, we don't have to go halfway through the alphabet and say, okay, here's what we'll do if something happens. We need to take our time and make sure there is something in plan in case, like Dan said, something happens overnight for some reason, then we're ready to go. But we don't want to discuss too much if the CEO now is not ready to get rid of the ambulance service.
Yeah.
Just my take.
My take is I also think it's important that everybody be kept in the loop. Otherwise, we're not gonna come up with a plan. I mean, it'll just be one-sided, so. Obviously, we all have a stake in it, but the only stake should be the best care for the citizens of Ottumwa and the county, or Walker County, so that needs to be the ultimate goal.
So anyone that's talked with the hospital, did they explain how they came from a deficit to a profit? What they did to get there, or what they would have to do to continue that?
City books.
Like I said, when I met with the new interim CEO today, he really hasn't had, I think he might have had some briefing on some stuff, but I asked him that question. Are you comfortable that the hospital's gonna hang on to the ambulance service? And he says, I can't totally tell you that right now. So I think that there's a lot that's still up in the air. He just started 3-4 weeks ago. So he's got a lot on his plate too. Anybody else have any comments before I turn it over to Sean Canto?
Maybe it's already been said, but it just seems like the hospital, if they want to keep it, they ought to keep it, but we need to be a safety net and be prepared in case something outside of even our local people's control, like you said, wants to change the scene or something. But I think they ought to do it, and we just need to do what we can to help them, encourage them.
I think we need to be open-minded to partnerships as well. You know, everybody gets behind or there's issues for everything. So, you know, and I'm not gonna mix my words. If people get mad, they get mad. I don't want this to be a power trip where one has to have it. There can be a partnership and it be successful. There can be a backup plan that has something that, you know, and that doesn't take anything away from anybody. That doesn't make, you know, what the job's done not important. Because again, remember, the citizens are what's important. If it takes a compromise, then it takes a compromise.
Yeah, an agreement can definitely be reached. If you're taking public dollars and putting it into a private entity, you have to have an agreement in place with deliverables. I know it was kind of to the cop thing. We never got that. You know, like they want $250,000. There has to be that, you know, agreement in place.
It's a business, yes.
Right, yeah. So, I mean, as long as we have something in writing, city, county, hospital, whoever, it can be done.
And as long as we have the money.
Yeah.
My take on it in the past, and this could have changed, is if the hospital was going to keep the ambulance service, they definitely were going to expect some kind of financial ongoing subsidization from the city and the county if they were going to keep it. But like I said, that was a year ago. So if they're making $500,000 profit now, maybe they're not going to want any kind of subsidy from the city and the county. That's the part that's really important at this point. And that's gonna have to be flushed out at some future meetings. But why don't we go ahead and,
I just have a quick question. So I just want to clarify. So if there was 600,000 in the hole and now we have a 500,000 surplus, and I'm not a finance person, but would that be a $1.1 million change?
Actually, more than that, because they raise all the salaries, bought equipment, fixed ambulances.
That's a significant change, and we don't know how that, so we don't know how that, because, I mean, if they're able to do that, I would like some tips. I mean, that's a significant change.
Not for something that waivers that they sent out, so we're not
Waivers for,
checking their records.
that's, okay. I think we were advised the same, weren't we?
Yes, and sent back a revised waiver, which waived your background. That.
So we don't know how long that took, like, we don't know if it was over a year, because they also bought cots and all the other stuff too. So it would be, okay, I just wanted to clarify that, that's significant.
Better than two, around.
The cots were not in that 500,000. The cots would come after the 500,000.
Okay.
They were not 250,000 apiece, and it was not a 1-year swing.
Thank you.
Wasn't it the number, you had the number of profit and you took the cots out of it? That's how it was explained to us. So actually the profit went clear down to like $130,000 profit.
And new ambulances haven't been purchased yet. that we're
Right.
Looking at this year, I mean, there's a lot of things that need to be done that weren't done.
I think there's four scheduled to buy. Isn't that right? Over 4 years.
That's what we're requesting currently.
Yeah, and just as advised, but it's hard to listen to and people have bits of information. I think it's important to note, and at these meetings, we did discuss the fact that much of the savings was a result of doing most of our third party transfers ourselves. Here can attest to that. So we were spending excess money to third party to do transports.
And see, you're proving our point.
Yeah. it was-
Some knew that, some didn't know that, so.
Okay, well, at this point, I'm gonna turn it over to our fire chief, Sean Camto, and he wants to do a brief overview of some emergency medical services. So Sean, I'm gonna let you have the floor.
So I will stand, if that's okay. So to give you a little bit of my history, my background, I've been in the fire service 34 years. Out of the last 28, I've been involved in fire-based EMS, either at non-transport or transport. Prior to my arrival here, I was the fire chief of a suburban Detroit department where we were fire-based EMS service. So I have experience in fire-based EMS and delivery of EMS services through the fire department for the last 28 years of my 34-year career. So what I wanted to do tonight is I saw the options that were actually presented, and I want to come up with a fifth option, which I think actually could be beneficial to not only the county and the city, but together. And as we talked about, I'm glad I heard some bringing up together, working in relationships. I think this would actually help some of that as we would move forward. So I just want to talk about, a lot of people don't understand where EMS came from and how it started in the United States. Pictures. EMS started as a necessity during the Civil War. So all the ways back as the Civil War, there were ambulances made out of carriages that were transporting patients. That was the first documented and known EMS service. But that continued into the 20s, and what you started seeing there anybody remember these? The old Cadillac ambulances? But unfortunately, a lot of the things that came through EMS came out of conflict, came out of war. For example, I'm sure nobody here in Ottumwa ever heard of the TV show MASH.
Nope.
No, guess not. But during the Korean War, that was the first time helicopters were used to transport injured patients. And they realized that they had a better outcome being transported quickly from the front lines to a mobile surgical hospital. They brought that back to the States. So a lot of things that happened, for example, in trauma came out of conflicts. In the 1960s, they actually had a white paper. They were finding that a lot of people were dying and getting injured in car accidents. And there was not a definitive care or pre-hospital care that was actually saving these individuals. So there was a white paper that was done called Accidental Death and Disability, Neglect, Disease in Modern Society. 3 years after that, President Johnson had a committee that actually was created through the Highway Traffic Safety Committee, and that created recommendations for national certifications, established uniform training standards, all related to EMS. So in the 70s, they started to improve care as it started being nurses, doctors, ambulance providers, healthcare administrators. They were seeing that statistically we were reflecting an abysmal state of affairs. How quickly were people getting transported to the hospital? Did anybody remember this show? Yeah. So people that remember that show, what that actually was doing is in the early 70s, Los Angeles County started looking at fire-based EMS using paramedic firefighters. So this show actually was there to show the community how this system worked. So today, a lot of the stuff is research-based, data-based. For example, the golden hour for stroke, quickly getting a person to the hospital to have interventions done, time saves brain. Same thing was coming up with cardiac arrest, getting hands on the person's chest for CPR and early defibrillation. But it's all being done focused on research. So how right now in the United States, this is from 2022, but the data is still the same. A lot of reports don't come out until later in the year or the following year. But this actually came from the Center of Disease and Control, the U.S. Bureau of Labor Statistics, how EMS is delivered throughout the country. 40% of it is fire department based. The next largest is private, not hospital based, and only 6% is hospital based. That is statistics from the country through the U.S. Bureau of Labor and Statistics. Also take a note that nearly 3/4 of the incidents that fire departments respond to are emergency medical incidents. And that pushed the fire service to be the largest provider of emergency medical services in the country. So today, there's a group that is called Nemesis, the National Emergency Medical Services Information. They tracked how many incidents happened throughout the United States in a 2-year period. It was 109 million incidents, and 83% of those EMS activations were requested for an agency that had transport capability. If we move on. So this is information that came from the Iowa Bureau of EMS. In 2023, there were 455,000 instant data records submitted to Iowa Image Trend. When we spoke with Iowa EMS, one of the things they did make a point of showing is not everybody consistently reports to the Iowa Image Trend. So that information may be a little bit skewed, but the information that they received was 455,000 data records submitted. So why is EMS requested? Now, again, this is through the Iowa Bureau of EMS, top 10 dispatch complaints. Now, what you need to realize is this is not just an Iowa problem. This is throughout the entire United States. Falls are the #1 incidents throughout the country that emergency medical responders go to, followed by 6 persons, breathing problems, and then traffic transportation incidents. Stroke, if you see here at the very bottom, is at the very, very bottom. Abdominal pain, unknown problems, convulsions, seizures. The majority of the incidents that we are responding to as emergency medical providers are falls, which then also relates to some traumatic events that go along with that. So, as I've been here, one of the things I was tasked with as soon as I got here was looking at EMS in Wapello County. And there were 4 suggestions that came up. And so one of the issues that come about, and I'm sure some people aren't going to like this, but I'm just putting this data out. So when you have a hospital entity, one, it's private and it's a for-profit model. And local governments, as you understand, have no control over that for-profit model. Even as you sat here today and said, there was data that you were requested to get, but there was a non-disclosure that was asked to be signed. So you have no control over, for example, staffing. Something that was discussed earlier was conditional service, going from paramedic to EMT. The actual service delivery model, the response times, patient care, and billing practices. You have no control over that with your citizens. So why is this of concern? Now, one thing I wanted to do was, and this PowerPoint is obviously going to be available, but I referencing material from not the fire service, but outside of the fire service. For example, this book, Municipal Benchmarks, discusses everything from HR to finance to public safety, including police, fire, and EMS. Managing local government services. This book here is through the International City County Managers Association. And then one which I did use, but again, through the International City County Managers Association, was Managing of Fire and Emergency Services. So I'm data driven. I like pulling data and I like referencing material that if somebody says there's a question, you can go back and find this information. So what happens is sometimes we don't want to explain what we're doing. When we don't want to be held accountable, but performance measurements become the common currency across healthcare. So the EMS structure for quality, best practices in designing, managing, and contracting for emergency services. The first hallmark they had, there was 12 hallmarks. The first one, hold the service accountable. Every ambulance service should be evaluated on its ability to deliver results in the area of clinical excellence, response time reliability, economic efficiency, and customer satisfaction. And this is accomplished through performance-based assessment. But again, in a private setting, as a local government, you have no control over that. So again, why is this a concern? Under Iowa Chapter 132, Emergency Medical Service Program Authorization, a responding ambulance to an emergency with only one person is against their policies and procedures. They states, provide at a minimum on an initial 911 or emergency call the following staff on each primary response ambulance. One current certified emergency medical care provider, certified at the service program, full level of authorization. Right now, that authorization level is at EMT. If there's a medic, it could be a medic. And one driver. On the second or subsequent calls, non-emergency calls when responding, should respond with one current certified EMT and one driver. So when we look at response times, why do we establish that? We look at measuring performance, and it gives decision makers a mechanism to look at how additional resources may be needed, and it also allows you to look at the benchmarks of an organization. So there's been some debate. So this was a paper that was written, emergency medical service units, average response times is 7 minutes from the time of call to arrival scene in an urban area. That time increases to 14 minutes, if not more, one of 10 being 30 minutes in a rural area. So what is Ottumwa? What is the city of Ottumwa? Well, if my pointer works, according to the U.S. Census Bureau, in 2020, when the census was done, the city of Ottumwa proper is urban. And that is based on the population of the city, the number of housing units, and the population per square mile in density. That makes the city of Ottumwa a urban setting. So for the city, is the city of Ottumwa getting the EMS delivery model of that in an urban setting? The answer is no. So how does that determine? Well, through response times, having multiple incidents occurring, not having enough ambulances in service, mutual aid long distance off. David, you had some numbers.
20 to 30 minutes per mutual aid service.
And that would be coming from where?
Davis County, Manhasset County, Albia.
So 30-minute response time for mutual aid requests coming from other organizations. And there's something else that's not here in Wapello County. There's no redundancy for a critical emergency service. There is none. Inconsistent service delivery, that conditional service, depending upon the day of the week, the time of the week, and the number of personnel. Yes, ma'am.
What is, help me now, no redundancy with a critical emergency service. Explain that to me.
So, for example, I think the best way to explain it, how many doors do you have in your house to get in?
Oh, two.
Two. So if one don't work, you can do what?
Go to the other one.
Go to the other one. So what happens is when you have multiple incidents that are occurring and you run out of ambulances, there's no redundancy. The system breaks. And so what you want to have is a critical care service. It's the same thing with water mains. There's nobody here from, if a water main breaks, they have the ability to shut it down, and it's a redundant system to be able to make sure that people still have water. Same with electric. If a line comes down, they have the ability to shut it down through redundant systems to keep electricity going. So I have looked at the four, and I came up with an alternative delivery model proposal. So it would be a two-pronged approach. Is that in that two-pronged approach, the city of Ottumwa would do fire-based ALS transport service for the city of Ottumwa proper. And then Ormix and the hospital would provide ALS transport and critical care transport for the unincorporated areas of the city. Now, what that also does is that proposal also allows for redundancy of a critical emergency service to the community.
You meant to say unincorporated areas of the county.
Unincorporated areas of the county. Yes. So if that service would come in, we already know the service and how it works with Ormix. I would like to talk about how it would work on the Ottumwa fire side. So what would that look like? There would be 2 advanced life support ambulances, 1 at each station, each staffed with 1 EMT and 1 advanced provider. And then also putting advanced providers on each fire company. So not only would they be on the ambulance, they would be on the fire companies as well, so our apparatus. That also helps that if an ambulance is out, you can now get advanced emergency care to a patient quicker if you're having to rely on that redundancy. Also having, which is the department I came from when I worked in Michigan, we had a fire and life safety coordinator, which worked with the hospitals as a community paramedic. And I would hope that we, as we talked about relationships, have that partnership with the Ottumwa Regional, where you can actually work telehealth medicine, having a nurse and a community paramedic coordinator actually go out to individuals. And I'm going to talk about that a little bit more and how you identify that, because again, I've been through this process. Also, and then working and talking with the sheriff's, or excuse me, the Ottumwa Police Department, doing a modified medical dispatch EMD process through that. It'll be modified. Automated station alerting. That actually helps the units get out quicker and takes a little bit of load off of the dispatchers as well. And then having automated vehicle locators to send the closest, most appropriate unit to the scene. If you're having a heart attack or if your house is on fire, do you care if the ambulance is blue or red? Nobody cares. They only care that somebody gets there in a quick and timely manner. So, what are the advantages of fire-based EMS? Well, again, fire-based EMS serves a large part of the population throughout the country. And we're also strategically placed. Fire stations are strategically placed around, for example, we have one on the north side, one on the south side. It also gives the ability with the work schedule for people to actually rest between the calls. And so we'll talk about some other advantages. Well, one, we already have the infrastructure in place. We already have the fire stations. What also the advantages are, it helps with the continuity between the first responders and the patients because they're operating together. They're in the same organization. There's the continuity of administration as well as the continuity of standard operating procedures. And then there's a unity of command that comes within that process. And finally, in that dual role model, not only are they performing extrications, they could be doing hazmat, specialty rescue, they're also trained as emergency medical responders as well. So there's something else that comes in when we talk about economies of scale, savings. Under the Fair Labor Standards Act, which I'm sure Barb has talked to you as City Council about numerous times, there's a 207K exemption for the Fair Labor Standards Act. Dual role firefighters who work overtime, they only get it after 53 hours. Overtime for a single dual role position, such as Ormix being a paramedic, or even if it would be through the county, they will get overtime at 40 hours. So there's economy of scale and saving that is different from fire-based EMS and other service providers. Other economies of scale that go along is that when first response EMS and transport comes under the fire department, it's combined in one organization. So you're taking away duplicate functions. For example, administration, training, support functions. As the city, we also have HR, we have a finance director, we have payroll. So those are all things that we're not duplicating them. And I spoke about this earlier, is the fire service, we're an all hazards, all emergency responder. And so we wear a lot of different hats. Fire-based EMS schedule has been shown to limit personnel burnout. One of the things that you can and these again are studies that burnout is significant to public health concerns because it has shown with workforce reduction, it has actually shown effects on patient care, and also the increase of using sick time and leave in the profession. But in fire-based EMS, the days off in between, and also having the ability in a 24-hour schedule that you put, for example, for the first 12, one paramedic might be working on the ambulance and then the other one on the engine company, and then being able to swap at night takes them off that unit as well, preventing some of that burnout. So we don't have to look too far. Muscatine, Iowa, they actually started a fire-based EMS program. And since then, they've been recognized by the Iowa EMS Association. They have had members, they've been awarded the EMS Service of the Year. Members have been awarded Paramedic a Year. And as it says here now, their sites are now looking at accreditation. I've been through that accreditation process also through CAS. It's a very timely process, but it's the tip of the sword of an organization. But now they're focusing, it shows that not focusing large or small, but focusing on the high level of service. That's what we want to do. Patient care and performing a high level of service for any community. So we look at funding, because funding is always a question. And the information that we have for funding, we have been, a lot of organizations have actually, we reached out to several organizations that actually help provide us with some of their funding and some of their data. Organizations that are similar to ours, and they have provided us with, for example, which I'm going to talk about here briefly, is the ground emergency management money, or ground emergency transportation money. We have that information as well. So in 2021, Iowa legislature passed the law, which we've all been talking about. So if the essential levy is supported, as I'm talking here, having that two-tiered system, that redundant system, well, can it be divided? Could some actually support an EMS system with Ottumwa Fire and still support what I was with Ormix covering the unincorporated areas of the county and concentrating on critical care transport? Absolutely, because in Johnson County, they did exactly that. The revenue was divided among 9 ambulance regions in the county, as well as portions of 2 other neighboring counties. So if done properly, this funding can also be, the essential service funding can be split. The Ground Emergency Medical Transport money is a program for publicly owned or operated ambulance services. Private ambulance services are not eligible for this money. So is Ottumwa, if we did it in Ottumwa Fire and EMS, would we be eligible for that money? Yes. We would, with the call volume within the city would be reimbursed between $400,000 to $500,000. I wanted to go on the lower side, if not more. And this amount was determined by looking at similar organizations from the information that Chief Cronin pulled and makeup of similar organizations and similar volume makeup. Fees for service. You're allowed, as part of your service, to charge fees for emergency medical service. That happens now. So it also depends on the level of service that you're providing. So those rates can be different, from basic rates to advanced life support rates to even critical care transport rates. So would Ottumwa Fire be eligible for this funding? Yes, we would be. These fees would be for service. These fees would go through insurance, Medicare, Medicaid, and private pay. Now, what I looked at is you have to look at the demographic of your community to understand what's your reimbursement rates. Where I just recently worked, our reimbursement rate was over 70%. I went kind of lower here because we are in an area within Iowa that has a lower income base rate system. So I went low. We would be reimbursed approximately $1 million for our incident volume. So when I was first tasked with looking at EMS, one of the things that I brought forward to Administrator Rath was looking at a pilot program. And pilot programs are really good because they look at the feasibility of what you're trying to do and also allows you to calculate and collect data to see if that larger scale project that you're looking to do would actually work. And the proposal that I showed you would be a long overall project, and it would give us time to measure our progress and have some matrix in determining the organization's success. So what does that measure? Again, you have to have matrix, you have to look at data. So ability for fire-based EMS to provide a timely response within the city of Ottumwa. The ability for fire-based EMS to provide a timely transport to definitive care. It will allow us to identify payer rates. It would allow us to identify reimbursement rates. It would also allow us to identify, which I did in my previous organization, users. Be it users, super users, and mega users of EMS services within the city. What you're looking at is 2 phases of that. One, you're looking at individual patients, and then you're looking at facilities that take advantage of emergency services to limit their own liability, and what they become is some of those super and mega users. So the Institute of Medicine defined quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes, and that it's measured in effective, patient-centered, timely, and efficient and equitable. So what would our next step be? So what I would be asking City Council is to allow us to put in place the pilot program. That would at least consider the option of doing the pilot program, I should say. We would work with the city administrator and city finance to establish the pilot program, looking at expenditures and reimbursements. And if the proposed budget supported, then present that information to City Council for approval. If approved, we've already started reaching out. Some neighboring organizations have helped us and put us in contact, for example, with medical control and direction, pharmacies for drugs and supplies. We would provide additional training to OFD members, because now, where they haven't been certified or cleared and trained in driving ambulances, they would have to go through that training now. Begin the pilot program within 60 days of the approval, and then run it at a 6-month minimum to be able to gather that data and information. So that's all I have for you, and I'm open to answer any questions you may have. And again, at the end, everything that referenced in that material is available. Yes, ma'am.
Yes, so I just want to talk about the ground emergency medical transport.
Yes, ma'am.
Program. So that, so if we are a partner with that, then that will cover the whole cost, correct, of or reimbursement, full reimbursement, unlike Medicaid?
It doesn't cover everything, but what it does is help supplement the cost, because Medicare and Medicaid do not pay at the true cost of what emergency transporting and services require. So they helped
Bridge that gap?
Offset.
offset it to an
And
extent.
you also, then get Medicaid reimbursement too?
You can, yes, and that's helping you pull over. David, if you want to chime in on any of these.
So you're good.
And then my understanding too is that there was a bill or a House study bill, that was introduced this year to help expand that program too. You know anything about that?
I do not know anything about that.
March 5th, I think it passed out of committee and is looking to go for a full vote, so something to push forward to. That's my question for you. And I have more.
I guess the question that I have is looking at the city's budget for this coming fiscal year is gonna be very tight. If a pilot was authorized to be done for city and signals in some of these funding streams that you've alluded to, are they eligible to be drawn down during that
The
pilot?
GMAT money would not be, because it's kind of like a year after where you bring your money back in. But for example, if we would transport, we would be eligible to bill insurance for that. So we would have that money as well that would come in and supplement. The largest cost to any service, any organization, is personnel. That's the largest cost. We also, prior to my arrival, we purchased an ambulance. The next largest cost, and we've just been in contact with a neighboring agency that found cardiac monitors that are brand new at a very low discounted rate. So those are number one cost to any organization is personnel. That's across the board. Now you can start looking at, as you go out and start looking at depreciation or purchasing ambulances and how long you keep those ambulances. And when you start pulling in maintenance of those ambulances and the cost of all those, how you depreciate that out over a period of time to you're looking at replacement. But right now it would be equipping the vehicle that we have. And then for the pilot program only, utilizing people that we already have in place in the department that are paramedics.
And you think doing a pilot for 6 months would produce enough relevant data?
We make,
Decision-making could be made from that.
with 3,100 incidents. So we make 3,100 EMS incidents in the city of Ottumwa as the fire department. So what you'll be looking at a 6-month period is about 1,500 of those incidents, and we wouldn't be making 1,500 of those. I would say in a 6-month period with one ambulance and service, we probably make 800 of those. But then what you do is you also then pull that data together and you start looking to make sure that there's always outliers within data. Sometimes the unfortunate thing is people can use numbers to make it say whatever you want it to say. But it would give you a better idea of what you're doing.
You said 3,100 what?
EMS incidents in the city last year.
How many of those are critical?
Well, so do you want to ask that? Out of those questions, probably 70% of those incidents nationwide are what's considered BLS incidents, and that's nationally. So 70% of our incidents probably run along the same lines. 30% of incidents that EMS services respond to are advanced life support or ALS intervention required. There even has been some studies to saying that out of those 30%, are they truly ALS intervention transports? Because such things as just putting a cardiac monitor on somebody in some services, or just doing blood sugar, because depending on what protocols are, could be considered an advanced life support service. But 70% of incidents that most places make are BLS,
What's BLS?
basic life support.
I see a lot of conversation about the city. Are we not covering the county as well?
No, so what my suggestion would be is you have a 2-tiered response. You have a response with the city covering within the city proper. You have Ormix covering the critical care transports as well as covering the county. Now, if they run out of units, we're able to help them. If they run out of units, they're able to help us. That helps bring in that redundancy into a system.
Okay, thank you.
Well,
Is this based on call time?
call time is actually a big consideration. So when you look at a call time, for example, of a transport, so from here to Iowa City or Des Moines, you're looking about an hour and 20-minute
I'm
drive.
just talking about basically they're quoting the amount of time it took an ambulance to get to a call.
Mhm.
In 25 years, I've seen fire department take just as long to get to a call as I've seen the fire department ambulance on scene waiting that long for us to come to a call. So
So, yeah, that was,
those numbers are all construed because we don't know what you're doing, you don't know what we're doing,
Actually-
you don't know what they're doing.
Well, actually, I can show you what we're doing because all our information is documented through the police department CAD system.
that's what I was gonna ask. Do we have,
But that doesn't always work because the chief can verify. I might call for an ambulance, but I don't know what the dispatcher's doing. She might be on another call. I don't know how quick she's gonna get the ambulance called. And so those call, even though we have a call time that we call for it, doesn't mean it's when it's actually dispatched.
Chief?
Well, I'd like to believe if somebody calls saying they're having a heart attack, my dispatchers will dispatch them immediately. If you would like statistics, reference medical calls.
Yeah.
Where fire and Ormix for the last 2022, there were 3,521. In 2023, there were 3,594. And
wait, can you go?
I'm sorry, my kind
What's
of
that?
so medical calls were dispatched both fire and Ormix to a medical call. In 2022, that was 3,521. In 2023, 3,594. And in 2024, 3,137. And out of fire-related calls, now again, these stats could not be accurate because we may categorize fire calls different from OFD. But if you're wanting those in 2022, 579, not medical fire calls.
Fire-related incidents.
Fire-related. In 2023, 582. And in 2024, 654.
Now, fire-related incident would not include, for example, a vehicle accident. That could be coded under EMS. That would not include, for example, assist citizen, which could be their smell of smoke in the neighborhood. So the fire-related calls, the city of Ottumwa per capita has more structure fires per capita than the city of Des Moines. In 2022, the city of Des Moines responded to 220 structure fires in 2022. This was data information that was done by the Iowa Fire Chiefs Association in 2022. And so population of Des Moines is what? 250,000? Our population is 25,000. We responded to 40 structure fires. So per capita, we responded to more structure fires than the city of Des Moines.
Is there any chance that all these divisions would have communications between each other so they can hear what's going on?
Absolutely.
That's not the case today, I don't think.
I think it is to a certain extent. We're all operating off the same VHF system currently. So when we go on scene, people know it. The word might be on different channels. There are other systems that allow for a better, what's the word I would like to say, interoperability. Unfortunately, that's not here. But we can turn to any channel and Ormix can talk to us and we can talk to them, as well as other rural fire districts within the county.
Okay, that's good news. Thank you.
Other questions from city council or board of supervisors for Sean?
I mean, I have general questions, just like broad, but I don't know, if
Go
this
ahead
is
and
the
ask
time.
them.
Okay, so I hear you said, the statistics for both of us being dispatched. Do we have actual response times of Ormax and, the fire department?
Those would be stats I could pull, reference, data captured on recorders for when those entities were to go 1023 or notifying dispatch they're arriving on scene.
If I also looked at the data through the CAD system, when the dispatcher puts it in, automatically goes through field ops, that we can pull that down as well.
Yeah, that's part of Central Square.
Yeah.
Yeah.
Okay.
Now, again, this may have been what Supervisor Patterson was talking about. I mean, it's coming through the recorder, but the dispatcher may be on another phone call or talking to somebody, and maybe the keystrokes don't happen at that exact second, but it's gonna be within a very close proximate time.
Okay. And this is just, information for me, and I hopefully, you all can probably answer. Do you, service out the Wapello County in rural right now? I have lots of questions, so jump in, people, if you have questions too. And I heard you say, Formex, you're looking to purchase 4 more ambulances, is that what I heard correctly?
That's our request.
Request
I
to
mean,
purchase 4?
They all need, like any emergency vehicle, they need replaced.
What does one cost? Quit.
Our current quote was $385,000, not a good. Empty ambulance is $385,000.
Okay.
So I would like to ask, I appreciate the chief gave a really great presentation. Thank you, chief. But I'd like to hear some more specifics about, the hospital's been doing this for 40-some years, and there's not been that many complaints to my knowledge, having sat in your chair before. So what's the issue here? And I heard, Mr. Cole Donald talk about the budget the other night on the, city council meeting. Why would you be willing to take on more debt when you're looking at a 1.6 or $2.6 million shortfall with revenue that's out there right now that we know is gonna be a problem for the city? And you could say, okay, we have the personnel, but you have to have a medical director, you have to have a billing person, you have to have medical supervision, you have to have training, equipment, supplies. And so you ought to be able to come up with a pro forma that would say, here's what it would cost us to do that. And what's the reimbursement and what's the net product right now?
We have put a budget together.
And I
think
guess
that'll be
I
shared
would,
then.
and I guess I would just say too, I'm asking questions because again, I wasn't part of that meeting. I did ask you if I could be invited to that meeting too, and I.
That meeting has gotten overblown out of proportion because
But I'm
I
just
asked a
saying in
couple of
general-
people, just because they missed the December meeting that we had at Bridgeview, which was open to the public. That was open to the public and most of the council were there, but a couple of them, Billy being one, had a family emergency. And Dan had a family emergency, went to a funeral.
And I
They
was
couldn't
sick,
be there.
and I emailed you that I was sick.
That's right. So, that was and it was the last day that Mr. Kiefer was gonna be here, so I wanted to have them have a chance to hear from him directly instead of having a third party. And I wanted the new CEO, Mr. Covert, to be able to hear the same discussion, because he had not heard it either.
Mhm.
So that
And I
was
guess
the purpose of that.
that's why
It was
I'm
not
at-
to make any decision, we just give information.
And that's why I'm asking questions today too, because I
Great.
wasn't,
Keep
you know,
asking.
so that's what I'm trying to understand also. So I think that that's a valid question, but I also want to make sure that I understand all aspects of it because decisions should have all pieces of the information too. And Tim has done a great job too. I will say he did sit down. Was able to ask him questions too. So I do appreciate that. But I just want to get a full picture. And we do have people from the ambulance here so I can ask questions
Ask away.
too. So I heard Sully, sorry.
So there was a question about the cost of ambulances. There are other options that services use because where you actually find that the truck is starting to age is in the chassis. You can actually re-chassis an ambulance, which means you're using the same box, which has been used, and putting a new chassis on it for 40% cheaper than purchasing a new ambulance. For example, a 2024 chassis ambulance that was re-chassised with 2024 Ford, brand new with less than 100 miles was $290,000.
And I want to add, because I do have experience with ambulance service at couple of different communities. It also depends on what size of ambulance. You can get a full-size ambulance or you can get a short box. Short box is going to cost you maybe 20% less as well. So really you have to base it upon your needs of do you need the longer one? Can you operate with the short one? And yes, the remounts, when we were doing it, we had 3 ambulances, we put them on rotation where once every 9 years you got a brand new ambulance. Otherwise there's a remount in between so that you could save money. So every other year we were buying an ambulance out of the 3. The other year we're doing a remount. So there's ways to save money when it comes to ambulances.
Does anybody know how many ambulances the hospital is running
4.
at this time?
We have 4.
4 vehicles?
We have 4, we don't have the staff to run 4.
I
But we do
understand, I'm
have
just talking
4
about vehicles.
operational vehicles. right?
Okay.
Correct.
How many can you run with your current staff?
2 normally.
2 to 3,
2 to 3,
24 hours, 2.
normally.
Our quote for a remount was 315,000 with 2 of the ambulances we currently have.
What does that mean?
To put light chassis, like putting up old box on a new chassis.
For what it's worth, to have 4 is important because as you can imagine with any vehicle, there's routine repairs and maintenance that is required. So if you're running 3, you need more than 3, right?
Yeah.
In theory.
And the important thing is, how many partners are gonna be involved and how much money are they wanting to, commit to? So you don't know where you're going until you know where you're going. That's a real important question to answer, I think. Even on your 6-month trial base, you can't trial base without partners involved in the cost.
Agreed.
Brian, did you have something you want to say?
Yes, one of my concerns, if you do the pilot program, is that that could cause the hospital to say, we're out of it, we quit. And so my proposal back to you for your consideration would be, if you design your pilot program just to be a backup provider when the hospital is like 15 minutes, 30 minutes out, and then you do the transport. It would still give you the ability to do some data collection, but not put the rest of the county at risk of losing the whole thing. Because your model is fine, but it leaves the county a little bit up in the air as to what could happen if the hospital does decide to not provide the ambulance service.
Well, there are services around the state. So if you would look at the number of EMS incidents that are happening in the city, and then the total number of EMS incidents that happen within the county. So I have that information here. So in 2024, there were a total of 5,119 EMS incidents in the county. So we could actually take that and say, we'll just use the even number. So 5,000 and 3,000. So there's 2,000 emergency incidents that happened in the unincorporated part of the county. Plus there was 598 transfers, critical transfers that occurred. So if you take that number, that's 2,600 incidents, if we want to use that, that would happen. There are services that are still providing service. You want to use any examples?
Yeah, good example, Knoxville running about 2,400 calls, Johnston runs 300-400 calls. So, and they're all sustainable services, even at that lower number.
So then again, it would go back to, it would still be a sustainable number. Now, transfers are where you're receiving as a critical care, where you're receiving a larger payment, but then you're also having the ambulance outside of its primary response area. As I was kind of talking about earlier, from here to Des Moines is going to be about an hour and 20 minutes. To Des Moines, an hour and 20 minutes back from Des Moines. And then you figure about 20 minutes at the hospital to actually transfer the patient over, get your truck back in service and head back. So if we take the 600 that are happening, and I like using round numbers and keep it even, so 2 a day, that would mean approximately 6 hours out of a 12-hour shift, that one truck would possibly be gone.
And then just to remind you, when we're looking at it from the county standpoint, we're not only looking at the county residents, we're looking at the whole of Walpole County, which includes the city of Ottumwa.
I understand that, and so am I, because by doing what I am proposing, is that you have a redundant system in place that you don't have right now.
That part is good, yes, get that.
So right now, do you do your own, you do transfers, right? So when you are doing transfers, are there 2 ambulances here still, still on, in the area?
Depends on the time of day and whether or not we can get the staff in. Most of the time, no.
Okay.
Like the fire department, we are short-staffed.
Yeah.
And not getting a lot of applicants, just like the fire department.
We're actually getting a large number of applicants, our HR directors here.
So, okay.
But if you're both short-staffed, I mean, instead of leaving somebody with chest pain sitting for 20 minutes, I mean, is a partnership that bad that where somebody could be there in 5? I mean, I'm just, I have a lot of questions, like, and I'm not asking questions to be disrespectful. I want to understand. It just, I don't know, it almost seems like we want to avoid a partnership when that's what would get the ambulance the quickest to the elderly person who's having chest pain. I mean, and you know, when I ask these questions, I want to set this forth. By no means am I questioning the ability of firemen or paramedics. They're my heroes. I think they're the best. It's just the shorthandedness in the operations.
That's kind of what the four options were the hospital offers. Partnerships and four different options, so.
Right.
And one of my proposals or our proposals is to combine dispatch. And to combine dispatch, you would be able to dispatch the best for the citizen, no matter where they're at. And we could add to that EMD, emergency medical dispatch, which you referred to, I think, just briefly.
Trauma.
And that helps with the whole concept of triage.
Well, that's, I'm familiar with the EMD and I'm also familiar with that whole process.
Right.
And so there's a lot more that actually goes into that discussion. So if you're looking at a patient, someone calling in saying, for example, they have an earache, is that an emergency? Well, they can go down through that EMD process and you would determine is the person having a stroke or are they just having a common cold and they're having a backup in their ear and now they have an ear infection. Is the ER the best place to take them? So within the city of Ottumwa, after 8 o'clock, there's only one 24-hour urgent care. Where is that?
The ER.
There you go. Also, if you would have a patient that you would call and say, well, contact your primary care physician. Probably everybody sitting in this room has called their primary care physician and has wished to get in the same day. Very rarely happens. So the proposal that I actually had is through processes that I've seen work is that going out and doing telehealth is that where you're actually going to those incidents with a paramedic, and as I talked about the partnerships with the hospital, having a nurse along, that you're actually doing a telehealth appointment with a doctor at the hospital. They're able to then prescribe drugs. They're able to then go possibly pick them up for the individuals and even go through the hospital pharmacy. Now, when I first approached the hospital, I approached as a partner and talked about going through our process and wanting to put an ambulance on. I asked for medical control through the hospital as well as working with them and using their pharmacy. I was told that would not happen. So when we talk about partnerships, I want to have the partnership with the hospital. Every organization I have worked for, we've had partnerships with university hospitals. We had partnerships with major hospitals. And that is how it goes together. This is not about, to me, as the chief of a profit margin or a profit center. It is about providing efficient and effective service to the community.
So I would just say, so OMG, is that what you called it? Is that medical dispatch or dispatch?
EMD,
I'm sorry.
emergency medical dispatch.
So I imagine that's gonna be more of a conversation because we would also need to bring the police in because, so I think that's probably.
Sheriff, police.
Yeah, police and sheriff and.
911 separate from all dispatch.
I would like to piggyback on what Bill said too. So if Ottumwa PD does respond to medical emergencies in the community, if somebody is overdosing, unresponsive, if we believe they're having cardiac arrest, we're all CPR certified. We carry automated AEDs and defibrillators in squad cars. And to give you statistics on that, and again, in 2022, 249, in 2023, 405, and in 2024, 509.
And these are medical?
These are medical calls that OPD officers went to. I'm not saying fire normals didn't go. I'm just saying
You were the first one
about
there.
that. 65-year-old having a heart attack, OPD is going to be rolling on that too, not just fire normals.
And you said you all are EMTs?
No, CPR, and we carry AEDs.
There are a lot of good users in the store. Okay.
Just so you think that, they're the only two entities that respond to those critical incidents.
Yes, I would think we look forward to when the fire department gets there and they can take over the CPR.
Yeah.
Say that again.
I said we like it when they show up so they can do CPR.
Oh.
You don't have to do it anymore.
ABC's ambulance.
So chief, how often do you
ABC.
have your people utilize the cardiac equipment on board?
I did not bring that stat. That's all,
Yes.
it's a program through the state. Oh, I don't know. I could get you that stats, but that's all tracked. So,
Okay.
yeah, I'm not sure.
So
How I can get that.
back to interject on the EMD, I'm a licensed EMD, EPD and EFD dispatcher as well.
What's an EPD?
So there's three different entities in dispatching. So there's emergency medical dispatching, which is
Okay.
EMD. EPD is emergency police dispatcher, and EFD is emergency fire dispatcher.
Okay,
So there's three different separate entities, and there's three different training classes that teach you the same exact dispatching, so you get the appropriate dispatch and the appropriate entities at all time. And that gives you the best certified level trainer or response at all time. So whether you send an EMT ambulance or an ALS ambulance, or you send a police officer, or you send 5. So you go through exact specific questioning as a dispatcher to get the right entities at all times. So that's very expensive training.
Yeah.
But that gets you, I don't know the exact statistics, but it's like less than 1% failure rate if it's done appropriately, which takes your liability off for any issues. Last time I talked to Raycom, who is our county radio provider, they suggested we're 2 to 3 years out as far as infrastructure to be able to do CAD system. I don't know that those numbers are 100% accurate, but as we were looking at upgrading our radios and our ambulances. So that was the.
when you say we, you mean? we're
Or
not-
mix it in
okay,
general,
Thank you.
because we're trying to get appropriate radios to go with dispatch, so we're all, the
So we're all
capabilities there and we can talk to everybody.
I think we're talking about two different things, so if I could interject, so I'm chairman of the 911 board, and our purpose in the 911 board is infrastructure for communications, which starts at dispatch, and we've been working on the radio system for the last several years, and I've researched that for Frog also. So the radio system is one thing, the CAD is something different, so that's dispatch. We can integrate some systems that exist today through state shared services. There's 2 different programs offered by the state that we could use. Nebraska County's using it. They're one of them, and they're doing it very well. That's a lot. That's a half county, half our size. And you set it up to work in your system. So your medical director is very involved in that, and we tailor it to work for us. I think there's a lot of missed opportunities there. We've talked about it, spitballed it forever, but never have I seen actual changes to local response to quit duplicating the services that we're doing today. We don't need to run a fire truck to every call formation is going to, and there's no communication between the two entities usually about, hey, I got it. Andy does the best job that I hear. Hey, stand down, we got it. That's just silly to run that fire truck clear to Pennsylvania Place, we're right next door. It's just one example. So, and if I could eject a few other comments, Mayor, just from my 30 years. So my expertise is local. I've been here, this is my hometown. I've been here 30 years, or 50 years, sorry. I've been a provider for 30 years. I'm an advanced EMT. I've been a service director. I've been involved in the EMS Association, which has been in existence since 1988. We have looked at system standards since 2012. 2010 is when the state of Iowa put forth that rubric to say, this is the standard we should measure ourselves by. I can tell you there's not a lot of services in Iowa that meet it 100%, but it's the ruler. You gotta have standards. I agree with the chief. But that's the Iowa standard. And so we do understand that there are significant challenges to us throughout Iowa, throughout this entire country. And unless you're in a real big urban center with plenty of money, which we're not, we're gonna have some gaps, but we gotta be creative in figuring out how we get there. One of the things I heard William Kiefer say, and I'd be curious to hear the comment from the new CEO, is he said, you can't cut out the core of our business and we still run the business. So partnerships are critical. The hospital has ran that since 1981 for 44 years. A lot has changed. So in the Board of Supervisor meeting, and I have offered to give this to council as well, I give a history timeline similar to the Chiefs, but local. So I explained to you what has happened in this community since the 1920s. And it's been back and forth. And so we've seen every different thing tried. We've seen the city run it in the 50s. We've seen the county take it over. We saw the hospital take it over. The other part of that story, just from a provider standpoint, and thank you for pointing out acronyms, Carrie, we're terrible about it,
Yes.
is the different levels of provider service. And so that's a question you need to be asking. So how many levels of providers? There's 2 BLS, basic life support, 2 ALS, advanced life support. So you have first responders and EMTs.
And then you have advanced EMTs and paramedics. We went to that finally in Iowa several years ago. It used to be all over the map as we grew and built capabilities. One of the other things to note as you look through history, and Chief pointed it out, in the early days of EMS, it was a load and haul. I mean, start with the funeral homes, talk about conflict of interest. And then we put a red light on it, because that helps. But as we evolved, we did not have paramedics on a service until 1981 when they finally came to Beavis, Iowa. Prior to that, it was a basic EMT, which was, we're gonna train you some ways to scoop a patient on a backboard, put them in the ambulance, which we could tell you horror stories about those old cons, and get them to the hospital. So a lot has changed. Not all services are equal. Are we talking about basic life support, advanced life support? The tricky thing about the 70-30 rule that Chief talked about is you don't know when the 30 is gonna happen. That's the hardest part. If we knew that, boy, this would be easy. But I think what we gotta figure out, the healthcare system is a very delicate ecosystem. Ask the hospital folks here. And we need to look at it as a community deal. I've talked for the last 3 years with different community partners. The community paramedicine is an idea that we have floated several years ago and looked at. I've talked to regional HRSA people about how do we fund it. I've talked to other community paramedicine programs in the country. The problem also goes back to funding. However, I think it's something that we should maybe get creative and look at as a community. There are existing programs in the state and they all look different. And the state is looking at it, not from a regulatory standpoint, but from a guidance standpoint. They're trying to figure out what works, what has been tried, what works, so they can give guidance to everybody else. I'm a proponent of not waiting until somebody else figures it out. Let's try something. But we've had some of those conversations in the EMS Association of Planning. The EMS Association, as I've said in public meetings before, is going to evolve into that advisory council. And that advisory council is that body that is going to do the metrics and the accountability and hold people to task to the agreements. And that is a board of all people interested. And the core of it is your service directors. We've not heard any of this conversation at the EMS Association. We meet, we exchange ideas, we exchange best practices, we do the what ifs, we run ideas up back and forth to figure out how does this work for everybody? How does everybody get what they need, get what they want? We take care of all patients and everybody does okay. The pilot project's not a bad concept, but I see definite flaws with it. It's gonna decimate a system that isn't necessarily broken. Does it have challenges? Yes, everybody does. But I don't know that Ottumwa Fire has enough staff paramedics to run a paramedic service in a single truck. Everybody has staffing issues. I don't care where you talk in the state, everybody has staffing issues. Muscatine Fire, my conversations with them is they have a revolving door of people because they burn out so quick because they do so many ambulance runs and transfers. They get sick of it. Scott County, fairly large county, just took over Medic EMS, one of the best regarded EMS services, CAS accredited in the state of Iowa. And they're having issues because their GEMT is not keeping pace. They're still $750,000 short. And it's a federal fee. We all know what's going on at the federal level. So I'm very, very concerned about what is that fee going to be? Is the state going to continue to do GEMT? So don't bank everything on that. We need to figure out how do we utilize the people we have, the resources we have. And if we go to the public and ask, I'm not going to make a recommendation to the Board of Supervisors to ask the public for anything until we can know exactly what this is going to look like. We're only going to know what that looks like by the people involved in the business at the table to design it. And they all have to be there. We can't operate in silos.
So that brings up a good point too. So so you and I talked about this, but, I don't know if everyone knows, but like, so who is this, board made up of?
That way, an appointment by the Board of Supervisors based,
But like,
if that happens,
not who, like people wise, but entity wise. Or,
Who's gonna serve on it, you mean?
yeah, like,
There'll be recommendations and we will appoint.
so it'll just be random people? So it won't be like representatives from certain areas? That's what
yes, there will. It'll be
That's
based
what
on, and I can give you that list. So the state of Iowa gives you a sample. We run that sample early on, and we did this years ago. If you do everybody in a recommended list, you have 30 people.
That's too big.
That's too big. So we go, okay, who do we really need? So here's the current draft, and this is flexible. We'd like to add a council person and maybe a couple other folks, but the core of it is gonna be the service directors from the EMS agencies in this county that have been doing this all along and have the know-how in what their service operation is and what their needs are. It also is gonna be represented from council, board of supervisors. And so we reduce that to like 14, 15 people. And then in that, we cut it in half. So there's 7/8 that's the core, that's those folks, a few elected and the know-how people. And then we have some ad hoc people that could bring something to the table. So we talk about ideas like community paramedicine, which I think is what you really should be talking about. I talk to River Hills because they have the plug into federal money. You know, they're the ones I talk to with HRSA to say, hey, can they be the partner? Can they help us partner in doing that? Public health, clinics, all these other places that have a piece in it, all those members we had in the healthcare coalition during COVID that would come to the table that met with me every week. So they wouldn't come all the time, but when we have a specific question or we're working on an idea like community paramedicine or telehealth or any of those kinds of ideas, they come to the table and go, okay, let's talk about this. Let's study this. Let's see if this fits. That's the work this advisory council needs to do. And it's going to be, forget what we know today. Let's come up with some ideas. Let's be open-minded. But we're going to do it together as a team and think about the entire county. Redundancy's a piece. He has a great point. However, we are limited. We are limited with certain constraints. If you pull big parts away from an operation that exists today, you can be threatened.
Right.
And what I don't want to see happen is something collapse. Is it perfect? No. Has it ever been perfect? No. In 1994, our mix was paramedic service of the year. You couldn't get hired if you were not a paramedic at Ottumwa Regional. Now they will hire EMTs because we don't have those people. One of the reasons we did the 4-county EMT pilot or the internship program through my office in partnership with Indian Hills was we got to address this shortage of providers. We got to get them out of high school. We got to get them in the feeder. And the college took it and ran with it last year, but it's grant funded. So is that some of the money, some of the use for the money if we ask the public for a surtax? We've got to be constantly training.
You're talking about the levy when you say money?
Right. So, but we have to have this all figured out in detail to tell the voter exactly what you're getting for the money you're giving. Because you want to know what you're paying for, right? Whether you're paying for EMS or going to the grocery store, you need to know what you're paying for. And it needs to be concrete.
Well, and it's important that it's gonna be a well thought out plan, because we already know the water rates and sewer rates are going up in a tough one this year. So people are already being faced with those increases, so you really wanna make sure if you're gonna ask for a special tax levy, you've got a concrete plan that's gonna get you somewhere. Kind of to reiterate and reinforce what you just said, Tim, it needs to be well planned out, and you have all the right players at the table. I'm sorry, Brian, go ahead.
We have a representative
Oh, I have
from the Hills, is that correct? Would you comment on some things related to training, just so you're here, you know, comment?
Yes, so we have taken over on the non-credit side, the training and have, adapted the training for paramedics down to 11-month program. We currently have approximately 15 individuals in that program. That was something that we at Indian Hills were very passionate about because we heard the scream of the need. And our advisory board, thanks to some of you who are on that, we do appreciate that, and we did that. We did last summer continue with the summer, it was called the summer EMT program for 17 to 24-year-olds. That some of them are still in high school. We have about 3 of those individuals that have gotten a waiver through the state of Iowa for their high school because they're still currently in high school to continue on in the paramedic program. So there's a feeder happening at the college that way for training. We continue to have an enormous number of EMT trainings throughout the region. We partner with our fire departments, we partner with our hospitals for that. And then obviously our community members who are interested as well can join into that. You do need to have your EMT prior to getting into the paramedic program. So it's not just going into the paramedic program. You do need to have it. Is this the same thing? We do offer advanced EMT. We have not been highly successful in running that, primarily because of, and I've heard a little bit, but not a lot, of who you need to transport and what each person can do. So an EMT can do these skills, an advanced EMT can do these skills, and a paramedic can do these skills. And so, and I'm not gonna get into who can do what, because that would be Tim. I would look to Tim, and I would look to my friends over there at Ottumwa Regional to help me with that. But there are only certain skills that you can do or qualifications that you can do. And so, and it is very, well, we have heard region-wide is the fact that we want paramedics, because then you can go out and you can do anything with whomever's got whatever issue. You can start the IVs, you can do the intubations, you can do all those. So. What did I miss? What am I?
That was great.
Okay, what am I missing?
Good, thank you.
Cole, did you have something you wanted to say?
Well, I, just back on the, EMDs, is that you have to remember that there's more to it than just training the dispatcher. Because there's certain regulations that if an EMT gets onto a call, then they have to stay on that call until either emergency services arrive or they determine that the call does not need emergency services. So if you have 3 dispatchers in the room, there has to be 2 EMD calls. You only have one dispatcher to answer all the regular calls. So you have to look at that staffing. So I don't know what we staff right now for dispatchers, but we may have to dispatch more in order to handle the call volume, which could cost us more. So it's not just simply training somebody up to the EMD standard. You have to meet the EMD standards as well.
I worked in Boone County, Columbia, Missouri as a dispatcher. We had 13 minimum and we staffed 17 to 18 on a shift.
And your demographic was?
The comparable cities.
Missouri.
How big are they?
150,000 in the city. But county, I can't give you the exact number county-wide.
One of the things I think we need to think about is, in what we talk about in our EMS association group, is we need to be getting at root cause issues, look at root causes, not just treat symptoms. So we talk about repeat callers, driving up the call volume. And one of the reasons that we have these stack calls that generates those pretty bad incidents where we have long wait times because they're so busy and the calls happen all at once. And it's a weird phenomenon that's happened the last few years. And it seems to be really prevalent in the mornings. We need to analyze that data to see, is there another option? Chief touched on it. Community paramedicine programs don't necessarily have to be a paramedic. There is a BLS level to that. If we could send somebody to their home to help them with basic things, maybe they're not a 911 call anymore. The fire service is extremely good at preventive medicine. So most communities, other than ours that loves to burn, it seems like, have done a great job in literally putting ourselves out of work in the fire service because we do so good at fire prevention. We need to look at that in EMS as well. So one of the other things that happened prior to COVID was decertification of Medicare, Medicaid billing and home care in public health. There was a fleet of nurses back in the day, you remember, at a public health serving the needs of these folks. And then private enterprise took it for a while and then they go, oh, well, there's not really money in this. So who's attending to grandma that still wants to be at home, but is continuing to fall, gets her medicine screwed up, needs a little basic care that would prevent that 911 call? Because frankly, there's some folks that call 911 because we've all they got. And so we need to look at that too. And that's a program that I think really look at it, we come up with a good solution for not a lot of.
Just FYI on that, I think Garcia plan on taking over public health next year, so
They did take that over. Public health is part of.
they're supposedly not going until July of next year on it. Mental health this year.
Well, I mean, Health and Human Services, yeah, it's
They were taking over
July.
county public health.
Yeah.
I don't think they're taking over, just, we really talked to one of the state has an intention. They just told us staff, state employees, the state supervisor paid this for the maintenance for, and this,
Sorry, I thought you meant, state level public health, so. So that, what you were talking about, I guess I must have I'm confused then. I thought that's what you were talking about with community paramedicine or the, telehealth.
Yes.
Is that?
Yes, correct,
Okay.
correct, yes.
Okay.
I think he was just talking about paramedic level, you were talking about.
There's different ways to do it. Yeah, but the concept is the same.
What you just said, and I'll bring up what he just said, it is I like. And let's face it, I mean, I've been in the EMS fire service myself. Sometimes when an ambulance is called, the unfortunate thing is it's not unfortunate because they were called. It's unfortunate that somebody might be lonely, or somebody might just need reassurance, or somebody might not, kids don't visit or whatever, which is basic. That would be perfect. That would be, somebody to go minor will care, help pick them up. Are you okay? I like the thinking of
compromise on different levels.
what we gotta do in this planning process, and I commend the chief for throwing an idea out there and having a proposal. We've got to, for a little bit, get comfortable being uncomfortable.
Yes.
And let's really look at our problems and figure out, are there ways we can address it? And it might not look like it does today. But we need to not be in a hurry to do it. And the reason I say that is because you guys can help sing the choir here. Everybody's walking on eggshells financially. And we can't afford to make a hasty decision, disrupt the apple cart, collapse ourselves financially, and lose our services to the public.
I agree.
There's too much at stake with our citizens to lose everything. There's just, I mean, at the end of the day, everybody in this room, I'll just take 10 seconds to say this. Everybody in this room, even though we might have different ideas, it's obvious that everybody cares about the person and what they can see. So we all have a goal. We just have a little bit different routes to get there. When truthfully, it's a good combination of ideas, but I do see everybody, the end goal being that person who needs the best medical care.
Well, that was my point of the message after that January early, when it was, we're just saying, are we, city, county, Formex, whoever, what issue are we trying to resolve and make sure we're all on the same page? Is it a financial issue? Is it a service issue? What is it at its core?
I can answer that. One of the issues we've been trying to chase for 30 years is having somebody on the hook with a contract for deliverables. And that would come with this process. The hospital, whatever model we pick, I guess we got a term, but if we had a contract with the hospital that said they're gonna provide X, they're gonna owe us certain services they provided to us for free for a long time, and certain deliverables that then we can, as public entities, report back to our public. Because I do agree, as Chief said, metrics are important, deliverables are important, and we have to share those. We've not done a real good job at that. We did tackle that conversation in our last EMS association meeting. But we really need to get into the weeds on figuring out some of these root cause issues. And sometimes the answers are simple. It's just asking the right questions.
So I have a question. So let's say this were to go to a vote. We have a plan that we identify is we think it's gonna work, but the people voted down. When can it be voted on again? Can it be brought forth? Do you have to wait a year?
Yes.
Do you have to wait? Yeah.
Nope, whenever you can schedule it. That's only happened once. So there's currently 21 counties in Iowa that have passed EMS referendum, and only one county has failed twice. That was Floyd. I don't know what's going on there. And I don't know if I gave you that spreadsheet, but most counties went full max. They went full 75 cents, which surprises me. The initial proposal I just discussed was a lot less than that. But again, when I asked, well, how much did they ask for? I can't answer that. I can't answer that until we created what it is we're gonna do and what that requires. Because I've heard other counties say, well, we just asked for what we think the public will fund. Well, that's not the right way to do it. Let's ask for the very least amount that's necessary. And I think if we can articulate very well, as the college did when they did their bond thing, the public will support it. But again, they have to have a clear idea of what it is. And we have a lot of work to do. And what we've done started doing is just educate the public about EMS in general, just like the chief did at the beginning of the presentation. So much of that the general public doesn't really know and understand. You haven't always had EMS? No, it's pretty young service.
Well, it's important, a clear idea as well, because if it went to a vote, some of us are over here and some of us are over here, or we all say we're here and then we're saying something else down here, it's not, we all have to.
That's why on the 29th, we'll have that meeting at Bridgeview with all the elected officials and the hospital, and everybody. Everybody understands what the levy is. And so there's no misconception, because that's all we keep hearing is we're buying ambulance, we're not buying ambulance. That ain't the purpose of it. The purpose is to make sure we have plans in place.
And that meeting will be facilitated by an experienced person who can help.
You call him that.
You got somebody else. Kayla Harrison has agreed to facilitate.
Awesome.
She's great.
She's great. She does it all over the state.
Yeah, she's great.
So I need a hand where you know that.
He didn't notify me of that.
Can't tell you.
So, yeah, I would like everybody to come and attend that.
Yep.
So everybody's on the same page, you know. Okay, so we don't have that talking.
Right, and you know, and again, I won't say this again, but my concern is when we get to a plan, when we get there, we as leaders support it. I mean,
That's why we.
there
want
are
our
gonna be,
elected leaders.
there's gonna be parts that Tim don't like, that I don't like, that the chief don't like, that you guys don't like. But if it's what's best, and that's what we agree on, we need to support it and not separate. You know what I mean? I make sense.
It needs to be the community plan.
Yeah.
Reliable and sustainable for all.
Right, and you know, that meeting is nice, and that's an open meeting where the community can come as well too, because, you know, it's their healthcare. I believe that the citizens should have some input on their healthcare because, you know, it's their town, and, you know, we ask them to trust us and help us make it better, so their input is extremely important, city and county.
Yeah, we wanted all fire chiefs, fire board presidents, anything to do with EMS to be there, so.
Yeah, but and there's so many more experts like instructors and, you know, people who build, people who handle it. I mean, it's just
Insurance.
so many different ideas.
But we're, at that meeting on the 20th, we're just hitting high level. We're gonna
No, but we
educate them,
wanna
we're gonna
inspire
educate them about EMS. We're gonna talk about the role of the council, what their tasks are, and answer, and get their questions. And it's up to that working group, that EMS advisory committee, whoever we put on it, to work out the details. Similar to your presentation. And I commend Dave and the chief for, it takes quite a bit of bravery to be bold and put out a new idea. I mean,
And there's a really good ideas there.
Nobody's open to change, but change is inevitable. So.
Mayor, I think we've all heard a lot of good information. I don't think we can solve it in an hour and a half.
Or that wasn't the purpose of solving.
I understand, but it's people getting information. And I would like to make a motion that we adjourn until we come back again on the 29th or whatever day that is.
Is there anybody else that really has something critical they feel they need to say before we go ahead and adjourn?
Just a couple minutes. We got a couple paramedics there. Do you guys want to throw in anything? Cause I'm not putting you on the spot. I don't want you, if you have something to say, take a couple minutes to say it. I just don't want to leave you out.
I'll just make, someone brought up a great point as to what this could potentially look like.
Would
For
you
those
identify
of you who don't
yourself?
know me, I'm Brian, I'm the chief nursing officer at the hospital. So I've worked closely with William in the past and Michael now, and of course, with the Orbix team that we have here. I think that the points being made about all of us wanting the end result being what it is, that we care for our community, the county and the city to the best of our abilities, is a shared message that we're all in need to be behind. I think there's a lot of information that a lot of folks might have questions on that I don't know if necessarily were accurately reflected within here, and none of those are big stakes. I really appreciate what some of the comments were being made around here, and so I think from our end, there's been a couple comments. I think Tim, you mentioned a couple of times where, take a big portion out of the book of business, what is left, right? If you take Pizza Hut, you can't serve pizza, you still got pasta and breadsticks. Great, what's going to happen? And so I think that is definitely a concern. I appreciate the comments around redundancy and the importance of having some additional backup plans. Using that example of a home and using the different door, I think the question that does have to be asked at some point is, what do you want your front door to be? Is it the organization that's been around for 42 years and has the staff that we have, 4 ambulances, the overall book of business, and having us as that front door is what we would love to be able to be, is that primary source. And if we have multiple crews out and being able to respond, and fire is willing to be able to assist us within those calls, I think that that's certainly something that we're open to as a partnership. And so I think that the next steps in this meeting is going to be a great one. And I think we'll get a lot of good information out there. I think to Tim's point, we need to have that plan when it comes to it of exactly what this looks like. There's going to be sensitivities to where that money goes, especially with the fact that, yes, a for-profit business is what's running the hospital and the paramedic services. And so, or the, Orbix, the EMS services. And so we'll have to be very organized when it comes to this. And I think if we keep that end goal in mind of caring for our community the best that we can, we'll come to the right solution.
That's the goal. Firefighters, you guys think so?
I appreciate what you just said. That was positive.
You guys good? You want some?
Good.
All right, just want to make sure everybody had a chance, because it's a very sensitive issue. You
All right.
guys are experts in the feelings.
Second.
Chris will take the roll.
Councilmember Cavanagh.
Yes.
Councilmember Reed.
Yes.
Councilmember Galloway. Councilmember Hoffman.
Yes.
Councilmember McIntyre.
Yes.
We are adjourned, and I just want to thank everybody again for coming to this meeting tonight to hear some initial discussion from the city and the county. This is obviously going to be an issue that's going to require a lot more planning and thought. But I think, we can get there eventually. We should keep it moving while or keep moving this thing for here. It was best for the citizens. So thank you very much for coming. Safe travels home.